Hello, Dr. Stein. Welcome, welcome. So we'll typically we have several people who join like throughout the talk. So we'll go ahead and get started. And then, we'll likely have multiple more people join after a few minutes. So for everybody who doesn't know, this is formerly Dr. Stein, now Dr. Somerville, who has come to give us a talk about this newly developed STEP clinic and to talk about some of our chronically ill pediatric patients who've transitioned over to the adult side and some of the unique issues that they face. Dr. Stein is currently the program director for our MedPeds residency and then also the director of the STEP clinic. So with that, Dr. Stein, I'll let you take it away.
Thank you. Also formally very blessed that Dr. Smith is my dear friend. All right, so I will jump right in. Thanks to everyone who's here. Please feel free to type in the chat box as I go or ask questions. See lots of familiar names who I miss and I'm excited to see. So I'm going to go ahead and jump right in. I have no disclosures to report in this talk. My objectives of this talk today is going to be to discuss some of the background and resources of the STEP program, really just make you aware of what we have to offer for your patients when they leave the hospital. And then I'm really going to deep dive a little bit more into spina bifida because of the patient populations that we see. They have really the highest prevalence and risk of inpatient hospitalization. And then we'll really try to hit some of the pitfalls of caring for a patient with spina bifida in the inpatient setting, make sure that you understand all of the kind of unique things that can go wrong when they're admitted, and then also discuss some unique inpatient considerations for any patient with intellectual disability to think about. So starting with just some questions, people can write in the chat. Whatever your answer is, how comfortable are you guys caring for patients with spina bifida right now? If you see a patient on your list in the morning and see that that's their diagnosis, is that like cringe, I'm terrified, or no, I got this, I'm really comfortable, I know what kind of things I need to think about with this patient? Now I got to find the chat box on my screen. All right, capital C, not comfortable, great. Thanks, Dr. Jaffe, even though some parts of this case may be familiar to a patient we took care of together once, and then some B pluses, love it. Do you guys know what's the most common cause of hospitalization for a patient with spina bifida? Think about patients you've seen. I see an A and a B, I think. Any other thoughts? All right, A, you are correct. This is the easier of the questions. So yes, the most common reason for hospitalization in these patients is going to be urinary tract infection or urosepsis. And then true or false, the next of kin of a young adult with severe intellectual disability is automatically considered that young adult's guardian. What is your guess on this as you're thinking about making decisions for this patient in the hospital? True or false? All right, false. I got one answer. You are correct. The answer is actually false. And I will touch on this a little bit later. All right, so what is STEP program? Just so you guys kind of know the basis of the work that I've been doing and that this exists at UAB, which is probably the biggest takeaway. So over time, more young adults with complex disease of childhood are living longer, right? Medicine has advanced. And so lots of folks are now living into adulthood and making their way into the adult medical system. There is, as you can see on this slide, a huge number of patients who've been born with chronic illness or disabilities. And now it's really estimated that over 500,000 children a year with special needs will transition to the adult system. And then there's a great study that shows that really less than 50% of these families with complex needs have received any sort of healthcare transition guidance. And that is really similar to what we've seen at UAB and with our patients in the state of Alabama, is just such a level of frustration, lack of support as they make that jump from pediatrics to adult medicine. Then you kind of couple that with what are the challenges that just any 18 to 25-year-old deals with. I'm sure many of you can even relate to this, right? As you kind of make that jump into adulthood, all of a sudden it's really on you to figure out your healthcare, right? Like your parents aren't coordinating your pediatric visit or your medicines. They're not there to remind you anymore of what pills you have to take in the morning. You may be losing your insurance status. You're kind of going through that unique time period of trying to figure out college or a job. Many people lose primary care during this time. And then for those who have any disease of childhood, we hear over and over again that there is so much discomfort in the adult providers that people see, that they feel like their adult physician really looks at them and is, obviously does not have education or comfort in taking care of their disease process. So adding that into already kind of the complex health issues that you have is really just a scary time for these patients. So STEP program opened in 2019. This is meant to be really a primary care clinic over in the Whitaker, run by myself and another MedPeds colleague. And we basically see any patient 18 or older with any disease of childhood. And our goal is to either provide consultation to them or to become a primary care home if we feel like they can't receive equal or better care in another clinic. And so for many of our patients who are really complex, that's going to be the case. We see patients really even in their late 20s and 30s who've tried to find primary care in the community and again really have failed to find someone who was comfortable with whatever their disease processes were. And that's in everything ranging from cerebral palsy to spina bifida to neuromuscular disease. And so as we've evolved, we've really started to build multidisciplinary clinics to reduce barriers to care for our patients. So we have quarterly clinics for patients with cerebral palsy, epilepsy, neuromuscular disease, patients who are either trach dependent or ventilator dependent, and then renal transplant patients where we actually bring the subspecialist to clinic with us to see the patients all together as a coordinated team, kind of a similar model to what they received at Children's. And then because we can't bring every subspecialist to UAB clinics, we have identified transition champions. So in almost every division of medicine at UAB, we've identified really a gatekeeper, somebody who's interested in these more complex young adults who either will help see those patients or who will help identify, who's the person in GI that should be seeing a patient transitioning with Crohn's. Okay, Dr. Russ loves to do that, so let's get that patient to him. Who's a patient who's a GI doctor who's really good with nutrition issues. Oh, who knew Dr. Weber had a nutrition degree and background? And so we've really tried to identify who can be those champions for us and our patients and connect our patients to those folks. We're also really lucky we have social work and physical therapy in our clinic to meet with every patient, and then lots of community partnerships. So this is just highlighting some of the goals of our clinic. I mentioned really like the overarching goal is how can we reduce barriers to care? The kind of pertinent part for this talk is that we talk extensively with every patient about what is their emergency and sick plan. So if you are to get really sick and you need to go to the hospital, do you go to Children's still? Do you go to UAB? Do you go to UAB urgent care? And so we're really thoughtful about making sure that patients are not coming to the UAB emergency room or to adult inpatient medicine unless they have fully transitioned over to UAB and that they don't have any like acute ongoing workup of their medical issues at Children's. So lots of time discussing all of those things. The patient population we see currently, so we've established 300 patients since we started. As you can imagine, the majority of them have some sort of medical equipment. A lot of the time they end up hospitalized because of malfunction of those equipment. And that's probably oftentimes where you'll see them on the hospitalist service. And then you can see a little bit about the breakdown of the patients we've seen. The majority have cerebral palsy, followed by genetic disease and then neural tube defects. So really what I want to go into depth a little bit more today on is spina bifida, in particular, because again, these are the patient population that we see that has the highest risk of inpatient stays, which is more applicable to all of you. So spina bifida specifically is the most common disabling birth defect in the United States and continues to be. And like I said, you can see life expectancy here in the chart on the right. Over 70% of these patients in the year 2000, or most of these patients actually were living to age 70 in the year 2000 and even more now. So these patients are growing into adulthood and we're going to care for these patients. So UAB is one of a kind. They have an adult multidisciplinary clinic for patients with spina bifida. They have a smooth transition plan into the health system. And so the majority of these patients over 21, when they're sick, are going to be admitted to us at UAB. There's a great study that really looks in depth at hospitalizations in this population. And you can see I pulled some of the interesting data for you guys. So 34% of hospitalizations have really been looked at and thought to be preventable. And then 35% of those hospitalizations that were originally thought to be preventable actually resulted in death. So this patient population is very complex and has a high risk actually of preventable death. The majority of this was really seen in non-academic medical institutions with less access to subspecialties. But I think, again, just an important reason for us to know what are the things that we don't want to miss and that we need to know about any patient with spina bifida. So I'm going to start with a case, and a lot of pieces of this really do come like directly from patients I've cared for and their experiences at UAB inpatient on the hospitalist or Tinsley service. And so really have seen all of these things happen before, but we'll jump in. So our patient today is a 21-year-old female born with spina bifida. She recently established in our outpatient step clinic, and today she called the clinic because she was having some confusion. At that point, she was told to come to the emergency room. So in the ER, her mother is with her. She reports about a 2 to 3 day history of progressive confusion. At triage, she's found to have a temp of 100, heart rate of 110, and blood pressure of 90/60. So starting off the conversation with the basics, what are the basic things that really you do need to know about Danielle and her disease process? So looking at this a little bit more, so always paying attention to what's the type of spina bifida, getting a good surgical history, what kind of equipment, tubes, devices do they have, and then knowing a little bit more about spina bifida related comorbidities. So what are the common things that all your patients with spina bifida are going to have that could be impacting their health and could be the reason that they're hospitalized? So running through this really quickly, there is a huge spectrum of spina bifida and what that means. There's an array of, varying pathology here. The majority of what I'm going to talk about today is the myelomeningocele. So those are the majority of the patients that we see with spina bifida. It's the most severe form of spina bifida, the most common, and then again, the most common to have complex issues and be hospitalized. But I will run through these. So spina bifida occulta, this is really a congenital condition, most often asymptomatic, that really is just a defect in the closure of the vertebral arches. It's not an issue with the spinal cord, but sometimes in adulthood, these patients can develop a tethered cord. So really an otherwise healthy adult with any sort of new neurologic symptom, hand weakness, leg weakness, could result in you finding this abnormality on imaging. A closed spinal dysraphism. So this is really, if you remember way far back to any pediatric knowledge you have, this is like that classic peds question of like, what are you worried about when you see the little tuft of hair or hemangioma on a child's lower back? And that's more common with this. It's also usually pretty asymptomatic, but patients can in childhood have some bowel or bladder incontinence and at risk of getting tethered cord syndrome as they get older. And then meningocele is when you have just herniated meninges and CSF, and this is usually repaired at birth without a lot of long-term issues. And then the myelo, like I said, is what we'll really focus on today, the most severe form. This is where you actually have no skin, but at birth, the spinal cord is actually herniated through the back. And a lot of times this will be repaired at birth. Now there's been a lot of modern advances that there are prenatal surgeries where you can repair this in utero, but most patients will have a lot of long-term sequelae from this. So touching on just like what are the things that almost every patient with a myelo is going to have that you should kind of be thinking about head to toe when you admit this patient. So I always like to know where is the lesion? Is it thoracic? Is it lumbar? Because this makes a lot of sense physiologically at what their comorbidities are going to be. So think about it, higher the lesion is more complex, right? Like the higher level of a spinal cord injury is going to affect every nerve root that comes below that. So as you can imagine, if you have a thoracic myelomeningocele, you can have everything from restrictive lung disease to a Chiari-2 malformation, hydrocephalus, because of the pressure that that's putting on the brainstem. And then kind of going down the spine, you think about neurogenic bowel and bladder, weakness and paralysis of the legs, a lot of scoliosis and clubfoot. So the higher the lesion, the more complex. Treatment of hydrocephalus, we all know the answer to this. A lot of these patients are going to have shunts, okay? Up to 80% of all patients with a myelo are going to have a shunt. So important to know what kind of shunt they have, right? Is this a VP shunt? Is it a VA shunt going into the atrium? And then the interesting thing is really just to know that it's there, right? Because that can always be a source of complications for these patients. So always asking caregiver or a patient or looking at their records, making sure that they don't have a shunt. Don't ever take that, don't ever assume that they don't have one. And then all of these patients have neurogenic bowel. And so kind of important things that you may not know that I wanted to share with you. So treatment of neurogenic bowel in these patients is really complicated. Like Miralax is not enough. Adding some Senna is not enough. Doing just an enema is not enough. They really have to have treatment from above and below. And so think about that as you're thinking about bowel regimens if they're having a lot of constipation, which they all will. And then I think the other piece I really wanted to tell all of you, because I had no clue what these tubes were, right? Like you pull up the shirt of a patient with spina bifida in the hospital and you're like, what are all these tubes coming out of their belly button? Is that a G tube? Is that they tell me they have a MACE or a Chait tube. What is that? And many of them will have several tubes going to different places. So the basics of this is for a lot of these patients will have what's called an opening called a MACE or a Chait tube. And basically these things are physiologically really similar. So the MACE is actually a surgically created channel that connects the outside of the abdomen to the cecum. And with that, basically what the patient will do is every day or every other day, they'll put up to 1 liter of flushed water through the tube to help with bowel emptying. So that can be also used just in place even of stool softeners or enemas. If they have a MACE or a Chait tube, usually they don't need a bowel regimen on top of this. So really just flushing the bowel out with water will help them to empty. And then the Chait tube is really similar. So that's going to be a more external tube that's again connecting straight to the cecum, and they'll do bowel flushes with that. This is definitely a common cause of inpatient stay and just outpatient procedures where the Chait tube will fall out, and IR are the folks to call to get that back in. You can also always put a Foley in it if it falls out acutely and you're trying to keep the tract open. And then the important thing to know about that is they really do have to be replaced every 2 months to 2 years. Neurogenic bladder. So this is also super important, right? We all already knew UTIs are the most common cause of inpatient admission for these patients. So what is the treatment? The majority of these patients have either agreed to say, or at least said that they will do intermittent caths. So self-caths every 4 hours, 4 times a day. Honestly, a majority of them a lot of them at least have their caregiver do this. So that's something to really think about. If you have a patient who's just sick alone in the hospital without a caregiver, who's cathing them? Do they have a Foley in? Is somebody keeping up with that regimen? And then the other piece to know about that I also learned in all of this, if you see another little hole coming out next to the belly button, a lot of them actually have a procedure called a metrophonoff, which is basically just an open stoma to the bladder. And so patients, you could see a hole on the abdomen with a small piece of plastic, a little catheter coming out that is for them to use to cath. And for some patients, that's a lot easier depending on the degree of motor skill that they have to independently cath their stomach instead of having to cath their own urethra. So it's actually proven to help with independence and autonomy in this patient population if they have a metrophonoff or an ileocystoplasty, which is really, again, the same thing. It's a surgery where basically they attach the bladder's basically expanded with a piece of bowel and then comes through the belly button to cath. So kind of same logistics, right? Like how can we easily cath ourselves through our belly button instead of having to reach the urethra when you have a lot of weakness? All right, so why is this important to discuss? You're probably all like, man, I know how to deal with constipation. I know these patients need caths, but like, again, these things are so important to think about when you're discharging patients, when you're getting a history on them, because again, these are going to be the things that increase their risk of preventable hospital stays. So we know that neurogenic bowel and bladder are actually huge risk factors for UTI, for kidney stones, for worsening kidney function. They actually are also a huge risk for shunt malfunction. So significant constipation and impaction can lead to a buildup of intra-abdominal pressure that then can back up and cause pressure on the shunt, which is super scary. And then incontinence can lead to skin breakdown, which leads to horrible ulcers, which is also a common reason that we see patients with spina bifida in the hospital. I'm sure all of us can think of one or more patients that you saw with a horrible stage 4 wound, who was not getting wound care or being turned, who was laying there and having incontinence. So things to really think about from a preventative standpoint. Pulmonary comorbidities, this is super important. I think the biggest takeaway, I mean, so these patients really, again, if they have higher spinal cord lesions, they're going to have scoliosis, restrictive lung disease because of their bad scoliosis, and then they're really at high risk for obstructive sleep apnea, from central apnea, and from hypoventilation that can lead to really chronic hypercapnia and respiratory failure. So just things to think about if you have a sick patient on the wards. Sadly, obstructive sleep apnea is very undiagnosed in this population. A lot of people overlook that. And then a lot of them also struggle with obesity because they've been wheelchair bound and unable to exercise. That also just puts them at higher risk for more severe OSA. And so sadly, it's thought that over 15% of deaths in patients with spina bifida are due to pulmonary comorbidities. And sadly, there are a lot of case stories of patients who really are just found dead at home, who go to sleep at night and are found dead because, and none of them have ever been worked up for OSA or known to even have trouble with apneas. So again, something to just kind of keep in the background of your mind when you see these patients. And then really, this is just to touch on it, but a lot of these patients struggle with significant mental health issues, significant malnutrition. I mentioned obesity as being huge. There's also a subset of them who are low BMI and malnutrition because they are totally caregiver dependent for their nutrition, or have even sometimes swallowing issues or choking issues if they have high lesions. So things that you may see. And then the majority of them really do have some degree of cognitive impairment or intellectual disability. I will tell you in my own personal experience, sometimes that is really hard to tell when you are just meeting a patient or having a basic yes or no conversation with them. A lot of them really can answer yes and no and tell you what they love to do for fun. But when you start getting into like the complex risks and benefits of a procedure and having them really teach back what you've talked to them about medically, the majority of them are very unlikely to understand or be able to have real medical decision-making capacity. So I stress that just so you think about that as you go in and share your medical plans or are thinking about doing procedures, it is so important to know what the caregiver situation is and to discuss anything that you're going to do with a caregiver present so that you know that there's somebody in the room who really can help consent and make medical decisions for these patients. All right, so now that I stressed all these long laundry lists of things that you guys need to know, we're going to go back to the patient and ask her all those great questions and learn a little bit more about her. So Danielle has a lumbar myelomeningocele. She says it was repaired at birth. She does have a VP shunt and tells you that it was revised 6 months ago. Her mother helps catheterize her bladder via the urethra, and then she does have a mace with the tube kind of present and patent on exam. She is wheelchair bound. She's got lots of specialists that she follows with, and then tells you a little bit about all of her supplies. So case continued, based on everything that we've just talked about. You've got her some basic vitals, very basic history. What are you guys most worried about with this patient based on everything that we've talked about so far? I love it. Everything. We need to rule out all of it. So I've already taught you so much just in the first few minutes, right? Like, we really don't know. This person obviously is sick. Their vitals are not completely stable. We're concerned about infection. We can't rule out kind of shunt or tissue issues. So obviously we need to get more history. So we will. And then again, just kind of touching on most common causes of hospital stay. So UTI being the most prevalent, but right behind that is a complication of a device, graft, or implant. So that includes, like I mentioned, anything from chate tubes falling out with horrible constipation to VP shunt issues to infected ulcers to aspiration pneumonia, sepsis, and then honestly also lots of crazy fluid and electrolyte disorders that I've seen in my patient population, everything ranging from hypocalcemia from poor diet to really high bicarbs with like impending respiratory failure. I mean, you'll be shocked at some of the electrolyte things that you'll see on these patients that have just been kind of living at home in their beds or in their wheelchairs. All right, so back to the case. So we get a little bit more. So our exam, we have no neurologic deficits. We've got our shunt imaging pending because we ordered that. Our UA has 2+ leukocyte esterase, some white blood cells and red blood cells and bacteria. And so then the patient gets admitted from the ER on antibiotics for presumed urosepsis. Sounds like a good plan so far, right? Sounds fair. Keep watching, waiting for that shunt imaging to come back. And then pretty quickly within the next day, we do get a urine culture back that is growing enterococcus. So currently, again, feeling pretty good. This is probably just urosepsis. Let's treat with antibiotics, make sure our vitals stabilize. So then day 2, you come in next day, hoping the patient's going to be all better, quickly can discharge them. And so now the patient's vitals, it looks like patient still now has a fever, right? Temp of 101, but heart rate and blood pressure look better. Our shunt series is back and we see normal ventricle size, no concern for hydrocephalus. Mom's at bedside today and says the patient's still really confused. Do you think that there could be something wrong with the shunt? So what would you guys do or think about next? You can tell her the imaging is normal, so there's nothing to worry about. B, maybe we should consult neurosurgery to tap the shunt since the patient is still having fever. C, would you just do a lumbar puncture yourself? D, would you get more head imaging? Or E, no freaking clue. Gonna call Step Clinic to help me now. All right, B, and call for help. So tap the shunt. All right, love it. We will get back to that in a second. Hold your answers. Lots of B's. So, and then kind of jumping into kind of how do we kind of reason through what this next step is. So true or false, does normal sized ventricles rule out shunt malfunction? I mean, if you see that shunt imaging and all of that is normal, does that mean that we can agree with the neurosurgery resident's initial evaluation that the shunt's good to go, no issues there. Perfect. You guys are good test takers. Would I ask this if the answer was true? So the answer is false. So imaging is really sadly not always conclusive, but we all wish it was, right? Like you want to be able to say like, oh, not the shunt in neurosurgery. Oh, someone talking. No. So you want to be able to quickly say like, oh, yep, not the shunt, especially the neurosurgery residents love to say that, right? Like, oh, it's not the shunt. Good luck. Have fun with their UTI. But really, it's so much more complex than that and kind of terrifying because for many patients, even with shunt malfunction, the tubing sometimes can still intermittently drain the fluid, and their system overall can have a lot like very low compliance. So sometimes the ventricles will still be small or normal sized, and you're not going to see overt hydrocephalus until it's really too late. So my takeaway from this is really do not ignore the clinical symptoms. Don't ignore the caregiver at bedside. If they're having neurologic issues, then that is something to take very seriously. And then there's a few symptoms that sometimes we don't take as seriously as we should. So a few of those that I've been mistaken on before, and Dr. Jaffe and I had an interesting patient in this situation last year, but behavior changes, something you kind of take for granted, right? And I told you this patient population has a lot of anxiety and depression at baseline, and in the hospital, you're meeting them for the first time. But sometimes I've seen shunt malfunction present truly as just increased apnea. So parents saying they're noticing snoring and gasping in sleep, coupled with daytime behavior changes. So my daughter's like crying and emotional more of the time. She hasn't really acted herself for the last few weeks. So all of those are things to really take seriously and could really represent something not draining correctly with the shunt. And so my takeaway on this is never go with the kind of beginning initial note on from neurosurgery. Always escalate to the attending or reach back out if there's something that quite doesn't fit. Sometimes it really is not as simple as seeing hydrocephalus on the imaging. And then this was another good takeaway. Can you even get an LP or an MRI in a patient with a shunt? And I'll cut to the chase. So one thing to know about shunts is that shunts can either be programmable or non-programmable. I didn't know this about shunts, but if they have a programmable shunt, it actually has a built-in magnet, and that is how it works. And it's really supposed to be MRIs are supposed to be avoided in these patients. So you always need to verify that and then discuss with radiology before you can get an MRI for anything. And then the other piece that I really didn't know was that really LPs are not recommended in people with myelomeningocele. It is recommended that you go straight to neurosurgery and that they actually tap the shunt, which is what all of you suggested in the answer box and was accurate. Staring spells. Yep, that's true too. Staring spells actually should be taken seriously. And then the other piece of what I told y'all about this patient. So what does it mean that she had a shunt revision 6 months ago? Is that something that means anything particular for this patient? So interestingly, if you're worried about a shunt infection, the highest risk is 3 months post-surgery. So if you have a patient who's had a shunt revision in the last 3 months, there's actually a very high risk of infection during that period. Staph is the most common bug, but there are lots of reports of anaerobes and other gram-negative organisms when you have a VP shunt, right? Because that tubing is going straight into the peritoneal cavity where lots of those bugs can live. I list out kind of some common symptoms of shunt infection, but all of this hopefully is pretty common sense. The one that was unique to me that I did see with a patient recently admitted to hospitalist a few months ago is who had a shunt infection was that they actually had streaking redness along their abdominal wall, which is actually reported to be pretty common in a shunt infection. So when the catheter gets infected or the infection is coming from the abdomen, you may see streaking or cellulitis over the abdomen. So that's something not to take for granted. I would always look at their belly and their chest wall. And then other complications after a shunt revision, just to have on your back burner differential, they are at risk for pseudocysts or abscesses, so never ignore the abdomen. And remember, some of these patients are paralyzed below the cord level, so they may not complain of abdominal pain. So again, really doing a good abdominal exam, keeping that on your differential. And then the other thing that was interesting to me is that sometimes after a shunt revision, they will over drain the ventricles, and patients can have really severe postural headaches. So that's something to think about if you're like, why does my patient have a horrible headache? The shunt imaging is normal. It could be just a side effect of a recent revision. All right, so you guys were right. What are we going to do next? Get the neurosurgery team called up, right? Like, make sure you've gotten a good shunt series, make sure you've got blood culture CBC on this patient, and then CSF cultures by neurosurgery. So we're not going to LP them or do other workup. And so what's next? So neurosurgery was consulted. This patient was found to have abdominal abscesses in the shunt catheter. And so the CSF did come back with pyuria concerning for shunt infection. At that point, recommendations are to externalize the shunt, start IV antibiotics. So the patient was transferred from hospitalist to the NICU at that point. And then in this case, after a prolonged hospital stay, the patient was improved, the shunt was internalized, and then the patient was discharged home. So positive ending. And so kind of just to round out the conversation, I could only include so many things in this one patient case, but there's so many more things. So I was just going to touch on some common pitfalls that I've also seen as some kind of takeaways. And then some of these I've already highlighted, but number one, don't forget the bladder regimen. Really that you need to be doing intermittent caths or making sure that there's a caregiver there to cath, right? Again, most of these people are dependent on their caregiver for caths. So you cannot assume that if the patient's alone, that they're having that their bladder's being emptied. Sadly, I know of a patient who passed away in an outside ER because they were altered and nobody knew to cath them, and actually had a bladder rupture and was sick and passed away, which is terrifying and completely preventable. The second thing we talked about already, Mason Chait tube dysfunctions or leaking. That's always an interventional radiology issue. The third is assuming that a positive urinalysis means a UTI. So like really jumping the gun to this conclusion that any sick patient whose urine comes back dirty has a UTI can be really dangerous for a patient with spina bifida. All of their UAs are dirty all the time. A lot of times they do grow positive bugs in their urine that are chronic bacteriuria, and they still have other things going on. So still really keeping that broad differential and ruling out those other things is always important. From an inpatient standpoint, these patients are so high risk for skin breakdown and wounds that are as a result of them being hospitalized. So never forget their skin, really like keeping an eye on it, making sure that it's dry and clean and that they have proper turning and nursing care while they're in the hospital is really important. Once these patients get skin wounds, they are so hard to treat. As I mentioned, a lot of them have home incontinence. It only makes things worse. Do not forget the shunt. I think we've already hit the highlights of that. Never ignore cognitive changes, choking, apneas. All of those are really concerning, that there could be pressure on the brain stem coming from a shunt that's starting to have dysfunction. And a lot of those are really initial symptoms. A few other things, so ignoring any motor issues, you guys would never do that, but these patients can develop a syrinx. And so if there's any sort of new motor issue in these patients, they really need complete spine MRI and neurosurgery to be called. They're all at risk of tethered cord syndrome, which mostly presents as acute back or neck pain. So that's also something not to ever ignore. I mentioned already the story about a patient of mine who had chronic hypercapnia and OSA that was never found previously. So if you see that, I urge you also to not ignore that. Some of these patients really might have such bad chronic hypercapnia already at the time they're admitted that they really may need to be evaluated for BiPAP before they go home to really prevent death. from apnea. And then the other piece I already touched on, but expecting their cognitive function to be totally normal just because they can have basic conversation with you is a huge miss, and can definitely result in harm. These patients really do need a caregiver with them most of the time for medical decision making. This is just a random fun fact that I've learned over time, that anywhere from 40 to 70% of patients with spina bifida have a latex allergy. How crazy is that? Never would have known that. There's a lot of multifactorial reasons for that. And a lot of it is thought to be due to the number of procedures and measures that they have as a baby or a child, that sets them up to be higher risk for latex allergy, and lots of issues that can result related to that. So always think about that when you admit the patient. It can obviously lead to more harm while they're inpatient. And then caregiver considerations: never assume that the next of kin is automatically their guardian. You always need to verify who's the medical decision maker. Do they have legal power of attorney or guardianship? And legal guardianship has to be appointed with court documentation. That is not automatically the family member. And then the last piece is really just, again, the importance of having a caregiver in all the discussions. And then last but not least is really, what resources do you need to know about when you discharge these patients? And I already touched on that, but so knowing your partners at UAB is really important. So our STEP clinic can obviously be a huge partner, whether there are patients or not. If you have a patient who hasn't established with us, who you think would really benefit from the services that we offer, you can definitely refer them there for hospital or discharge follow-up. And then just knowing that we do have a comprehensive spina bifida clinic at Spain Rehab, and Danielle Powell in rehab really runs that clinic. And how you can reach us. So if you guys have a patient that you're concerned about and want to get them in from hospitalists, we do have, you can message an impact to the STEP clinic access pool. We do now have a consult service. UAB Medicine has a way that you can the patients can self-refer. And then obviously, here's my contact. All of you can email me if there's some sort of patient or special consideration, or obviously if I can help you guys in any way navigate. And so to wrap up with just some takeaways, care of these patients really is best done with a multidisciplinary team. As you can imagine, that there's not a lot of that around our state. So patients really are driving and coming all the way to UAB from as far as Mobile and as north as you can go in Alabama for the level of care we can provide here. And because of that, that means more of these patients will be admitted at UAB and in all of our care in the adult hospital world. So many of their hospitalizations can be prevented. And so it's so important that we really continue to educate rural and local and UAB doctors about some of the considerations we talked about today. And then the biggest takeaway is just remember who your community and institutional partners are, and certainly reach out to all of us for help. And that's all. I will take questions and stop share if anyone has anything. Everyone's expert now.
I don't have any specific questions, but I think that's very educational and very pertinent to our patient population. I mean, we have a ton of, and disproportionate, I guess, because other services are always capped. So we have a not insignificant number of spina bifida patients or CP patients that come in, and all of this pertains to all of our patients. So I think this talk's very helpful for us.
Thank you. And yeah, that was the only other thing I meant to say somewhere in the talk that I never said, is that a lot of the same issues really and considerations apply to patients with cerebral palsy and genetic syndromes. I mean, it's a different disease process, but a lot of similarities also in the unique considerations and patients not being able to really advocate for themselves and their own medical issues. So thanks for having me. I appreciate it.
So if there's an inpatient STEP patient and we have a question, the best way to get in touch with you guys is through the pool.
Yeah.
If you have questions. Okay.
Yeah. Direct portal message to me or to the STEP clinic pool, which my nurse is in literally 10 hours a day, every day. So.
Okay.
All right. Thank y'all. Happy, what day is it? Tuesday. Bye, everybody.
Thank you.